Good afternoon. I'm Dr. ezamBechard, board certified in internal medicine, and I've been asked to comment on the case of Carol Coates. Today's date is June 26, 2011. I've been asked specifically to comment on her for a preoperative assessment and perioperative management of her medical conditions. Carol is 86 years old and over her lifetime has acquired some significant health problems. The most significant in regard to a potential surgery in the future would be risk for coronary disease. There is a family history of coronary disease, however, she does not manifest symptoms or signs to suggest that she has this condition. I feel it would be important to have an electrocardiogram available to evaluate for any significant abnormalities, and if they are present, consider stress testing. However, at this point in time, given that she had a surgery just 6 months ago and tolerated it well, in the absence of any major EKG changes, there would be no further cardiovascular workup required. The other significant condition is a history of venous thromboembolism, including a prior pulmonary embolus and DVT, and her current use of warfarin therapy. I would recommend that she continue on her warfarin therapy up until 5 days prior to surgery and then stop the warfarin. If surgery were delayed for any reason, she would need to be placed on bridging Lovenox therapy. During the perioperative period and post-operative period, she would require aggressive DVT prophylaxis in the form of SCDs and early Lovenox therapy, as well as early mobilization as allowable by her surgery. The next issue is she has some underlying lung diseases manifest through a pulmonary function test that demonstrated mild restrictive pulmonary disease and a CAT scan that demonstrated fibrotic changes. She also has had demonstration of hypoxemia at high altitude, though not at low altitude. Given her pulmonary limitations, I would recommend perioperative oxygen therapy to keep oxygen saturations significantly greater than 92%. Additional measures during the postoperative period, I believe it will be important for Carol to be placed on a calcium supplement, calcium carbonate, or another formulation in a dose of 1,500 milligrams daily, along with vitamin D, 400 international units to prevent osteoporosis. Another important point in her case is that she has been on chronic steroid therapy and has an elevated white blood cell count of 16,000. I believe this is likely explained by the steroid therapy, and any signs or symptoms consistent with infection would need to be investigated. Her urinalysis is negative, so I think the elevated white count is related to steroid therapy. But I question the necessity for prolonged steroid therapy. Prednisone use in degenerative arthritis is useful if it is an inflammatory arthritis, and I wouldn't necessarily recommend it if it is merely a degenerative without inflammation. I would rather favor steroid-sparing therapies, including non-steroidal anti-inflammatory agents, which she is on, and opiates, which she is on. I would maximize those therapies instead of chronic steroid therapy. I have reviewed the images of Carol ambulating and undergoing range of motion exercises, and I believe that Carol suffers from significant impairment of her range of motion in her lower extremities, and I believe this impairs her normal activities of daily living and significantly impacts her quality of life. Reviewing the images, I see several problems, including a probable malaligned right acetabular prosthesis and possibly some on the left, as well as a bony avulsion of the greater trochanter on the left. Based on the impairment that Carol has, I believe surgical intervention is a worthwhile measure given my concerns and recommendations regarding her medical conditions as stated previously. Thank you for asking me to participate in this case and offer my comments. Thank you.